Hello and welcome to another episode of Healthy Talks. Today we have the amazing Anne Llewellyn, who is not only just a registered nurse but also a nurse advocate and nurse case manager. Hi, Anne. Welcome to Healthy Talks. Thank you for being here.
Hi, Julie. How are you? Thank you for
I'm
inviting
good,
me.
thank you. So we've spoken about your background and what you've accomplished in your amazing career, but what inspired you to become a nurse advocate and case manager, and how has your role evolved over the years?
Well, basically, I've gotten into case management in the late 1980s, 1988. And I was actually just told that there was a job opening for a case manager. And at the time, there really wasn't a good definition or a good job description for a case manager. But the person who invited me to get involved was working as a case manager. And she said, I really think you would love this. It's a way to use all your skills and to help people, go from the hospital to home who have complex conditions.
Mm.
So I went for the interview, and the person who interviewed me asked me that question, what did I think a case manager was? And I said, well, I really don't know, but I think it's something that I would like from what my friend told me. So she said, well, my definition of a case manager is someone who uh, knows the patient, helps them understand their condition, and helps them get the resources that they need when they need it at the right time in the least restrictive setting. And that resonated with me because as a nurse, a critical care nurse, I knew we kept people way too long, maybe even in the intensive care unit. They were doing very well. They could have gone to a floor, but we kept them just because we weren't coordinated enough to move them to the next level of care. And today in 2024, that's very, it's not common, it's commonplace that we do move people to the least restrictive setting, sometimes too soon. Unfortunately, in 1988, we weren't moving them fast enough. Now we're moving them too quick. So it's a cycle, but my role is to help coordinate care, help with the transition of care from one setting to another, to work with the healthcare team to make sure they know what the patient's needs are, what the patient's worries are, and to kind of be a voice for the patient. So that was how I got into case management. And I did that for a number of years, catastrophic work with people with spinal cord injuries, head injuries, and really found that it was really like the niche in nursing that I really liked. And
Yes.
because it helped me help people, I get them the right resources so they could do the best that they could do. They could live with conditions that we think, oh my God, how does anybody live like that? Quadriplegic, spinal cords, head injuries, and then also help the families cope, because when somebody gets sick in a family, everybody's affected. If it's the father who is the bread maker, now how are we going to get money? Who's going to go to work? The father is sick or injured or can't work anymore. So it helped me and really opened many doors to the different resources we have in the United States to help people deal with these complex conditions.
That's right. And in our chat earlier, you mentioned that patient safety is a critical issue globally. What do you believe are the most pressing challenges in improving patient safety in the US healthcare system at the moment?
Yeah, I think patient safety is so important. People get injured, and really not at any fault of the healthcare system, actually at any fault of the individuals within the healthcare system, like doctors, nurses, therapists in the OR. Nobody goes to work and this patient is going to be injured today. But things happen. It's a human business, and it's something that we really need to look at. to be able to prevent injuries. We have a lot of safeguards in place. When somebody goes to the OR, before they get put to sleep, they're asked, what is your name and what are you here for? And they know that they're going to be asked those questions. So they know they have to say their name and they have to say what they're there for. I'm here for appendectomy. I'm here for, you know, a colostomy or to get my gallbladder out. And they know that. So they tell the team, and the doctor is part of the team. The scrub nurses are part of the team. Anesthesia is part of the team. So everybody hears at the same time what the patient is here for. And then that gives us a good roadmap to go forward, to put the patient to sleep, to do their appendectomy, to take their gallbladder out. Unfortunately, things still go wrong. Anesthesia could not work right. And the patient gets anoxic and it has anoxia of the brain. Or they take out the appendix and they were supposed to take out the gallbladder. You know, so we still have human error, even with the checklist, but with the checklist, it has decreased dramatically. So it is something that it's called continuous quality improvement. We always have to be alert, awake. You know, I know a woman, her father had a liver transplant and he did very well after the liver transplant. He was doing good. The doctor came in to see him like 2 days post-op, said, oh, you're going to be on the golf course in 3 months. You're doing great. The liver was working, everything was going well. The man fell out of bed that night because and the family was there. They watched him get up and he stumbled, fell, broke his hip, got all kinds of infections and died within a week. So, I mean, things happen in the hospital. And I know that woman who that happened to always felt so guilty. We didn't know he couldn't get up. We didn't know we had to help him. And so it's education, it's communication, it's being proactive. You know, beds today, if a patient tries to get out of bed by themselves, they have alarm systems. This system was turned off because the family was there. And he was moving around in the bed and it was going off. So the nurse came in and turned it off. Now, if that would have been on, maybe they would have been alerted and it would have been prevented. So we try, and medication error is the same thing. People are supposed to go and check the name, check the drug, make sure it's the right patient for the right drug, the right dose. If you don't do that, you give the drug to the wrong patient, that's a medication error.
Yes.
Because you didn't follow the protocol. So those are the things that they're the major system issues. And the reason why people don't follow procedures is they're too busy, or the family says, can you turn off that alarm because my father keeps moving and he keeps going off and it's really bothering him. I mean, it seems logical to do that with the family sitting there, but the result was a death. So, you know, again, we have to continuous quality improvement and being able to make sure the patient, the family, the doctors, everybody's on the same page. Very hard because it's a complex system, but something that we continue to work at.
And just about you saying that the patients, that this happened to them, this terrible thing that happened to them, and the family was around. What strategies do you use to help educate and empower patients and their families to manage their health effectively?
Well, education, you know, when they were asked if they could turn the alarm off, no, we don't want to turn the alarm off because that alerts us if there's a problem. You know, we can help reposition him in the bed so he's more comfortable, but we really don't want to turn the alarm off. Really helping people set realistic expectations. Things don't always go the way they should, but if we at least know about it, we can help correct it. And to communicate, like, talk to me, tell me when something is wrong, and that we can address it. But, people don't want to bother the doctor. They don't want to bother the nurse. She's given meds and she said she'll be in. So we have to wait. It's things like that. And you go into a hospital today, it's very busy. Everybody's running around. People don't seem to have time. So
Mm,
people keep those things to themselves. But like we hear when we go to an airport, if you see something, say something, ask a question. Don't assume everything is okay. When I was in the hospital, my husband was there and the nurse came in and hung an IV and he asked her what that was for. And she told him, and he said, well, we didn't know we were going to get that IV. She went back and checked
mm.
and it was the wrong patient.
Oh, really?
So unless you have somebody there at
Mm,
people should have somebody with them while they're in the hospital, things happen. And
that's right.
sometimes they're not critical. They call them near misses. It was a near miss. If maybe I was allergic to penicillin and penicillin was in that IV, I would have had an anaphylactic reaction. But it was just a regular IV. I forget even what was in it, but it didn't do anything. So it
Mm,
wasn't. It was a medical error, but it wasn't a fatal medical error. But those still count.
that's
So
right.
having in-services, education for the staff about new procedures, about how to do, that's why risk managers are in place in hospitals to look at all the incident reports and to see if there's any kind of uh, things that are happening all over the hospital versus in just one unit. Then we might have an in-service, how to use equipment because it's not being used properly and we're seeing the results in medical and
Mm,
incident reports. So it's those kind of things, education, communication, slowing down. Really, we're understaffed in hospitals.
yes,
People are sicker, and sometimes we just make mistakes. But the big important point is to recognize it was a mistake and to fix it. I
yes,
mean,
and to
to
learn from
address
it.
it, to report it and address it, because that is, if we do that, then we can get help, we can have somebody looked at, we can rectify it, and we go on.
That's right. And tell me, Anne, can you share an example of a particularly impactful case where you coordinated care for a patient and what lessons you took from it and what lessons we can learn from it?
Um, can you repeat that middle part? You got cut out.
Sorry. Can you share an example of a particularly impactful case where you coordinated care for a patient and what lessons you took from it and what lessons we can learn from it as well?
Right. Okay. Well, coordination of care. Making, I would have a patient that I was working with, and we really didn't know what was going on. This patient had a condition. The wife actually worked at the same hospital where the patient was in, but she couldn't take off all day to go sit in the room and wait for the doctors to come in. And she wanted to know what was going on with him because he was getting worse. So I called the hospital, talked to the case manager at the hospital, and we had a family conference. We had the doctors come in, we had the wife come in. The patient was supposed to be there, but he had to go to dialysis, so he wasn't there at the time. But the doctors did come and the wife was there, and we had a really good discussion about where the patient was medically and what was happening and what their thoughts were about
Hmm.
prognosis. And it turned out after listening to the doctors that they really felt he really didn't have, he was not doing well and he was really at end stage of his disease. And so they recommended that he go on hospice. And so the wife was like, well, no one ever even told me that he was that bad.
Mm,
And she said that, so the doctors really worked with her to understand it, understand how the disease progressed. And it was a good communication. It was a good learning experience, I think, for me, for the wife, for the doctors even, because they felt that they were explaining things to the patient and the wife, but they weren't really, it was like, well, this is just how it is. So it turns out that after we had that meeting, that same day, right at the same minute, the wife said, well, we have to talk to her husband. And he was in dialysis, so we all went to dialysis. And he was in a little cubicle by himself, so the main doctor started to talk to him. And he responded, he said, I understand what you're saying. He could hear, and because he was kind of out of it, but the doctor made sure that he could understand that, I'm your doctor, I'm Dr. X, and we wanted to talk to you about your condition. We've talked to your wife, and she wants you to be aware of it so you understand. And he went over everything very simply, didn't really use medical terminology with this patient, but really explained to him how things were. And he said, I understand. And he goes, and the doctor said, we would like to recommend that you go on hospice. And then he explained what hospice was, that this will help you be comfortable, until we can see what's going to happen. He never mentioned death. He never mentioned you're going to die in a week, but he just told the patient this would help him be comfortable. And the man agreed to it, signed all the papers right there, got hospice involved. And it was interesting because I felt good about that we had that meeting, that we had everybody in on it, that the people, the doctors, they explained the situation so the wife could understand it. And then she saw that her husband understand it. It was an emotional meeting. She was crying, he was crying.
Enjoying this episode? Ever thought of starting your own podcast? Podup.com is your go-to. They've got everything you need to run a pro show, including 35 or more AI-powered tools for success. Sign up today for a free starter account and get 15% off with the code HealthETalks15. The code is HealthETalks15. Plus, check out podallies.com for a done-for-you podcasting experience, complete with website, social media, and editing. Start now and let's launch your podcast together.
But it served a purpose of improving communication and educating the patient and the family to have a realistic expectation he was not going to get better. So actually he went to hospice. I think it wasn't that same day, it was the next day. And the wife called me and said, this was the best thing. It was a beautiful hospice unit. And he had his own room, which before he was sharing with another patient. He had his own room. His family could come. They could all talk to him. They laughed. They cried. They even had a beer. He had a beer, which he really wanted. And so and then he passed like the next day or two. But the wife just was so glad that that experience happened. Because it gave her the ability to help her and her husband make a realistic decision, which they didn't even know they had to make until the meeting.
That's incredible. And you mentioned in our previous discussion that a man was homeless after an amputation. How do you approach advocating for patients who face such socioeconomic barriers?
Really hard, very hard.
I can imagine.
I mean, there's a saying in case management, when people are need resources that maybe they don't have as part of their insurance policy, and they can't get things. They can't stay in the hospital longer because they don't meet criteria to be there. And when those decisions are made, we as case managers have to try to find other resources, community resources that can help people. It's a saying that a friend and a past president of our professional organization, we're not 1-800 hell no case managers. Our job is to hear what the decisions are from insurance companies, from doctors, and then to work in the confines of what we have to work with to meet the needs of the patient. Sometimes it's telling the team, the patient is not safe to go home. This was a homeless patient. He couldn't go back to the street. You know, some people are discharged, believe it or not, back to the street. They have a cold, they can get antibiotics. And most hospitals today will give the person a dose of antibiotics to take just so they can leave. We don't admit everybody that comes in because we can't do that. You know, there's not enough room. But this man was really sick. I mean, he had the amputation, he lived on the street, had infection in his leg, so he still needed IV antibiotics. But, you know, they wanted him to go home and get it. And there was no home. Even going to a shelter wasn't. The shelters don't accept people who need ongoing medical care. So there really wasn't any place. So it's our role sometimes to say, we can't discharge this patient. And there are hospitals that take care of people way longer. I mean, I'm talking months after they should have gone home. But because they have no safe discharge plan, they keep them in the hospital and they take the loss for that. Hundreds of thousands of dollars go into that every year in the hospitals across the country. Now, this is the United States. I don't know what other countries do to meet those needs of homeless people, of people who really are mentally ill and don't want to stay in a hospital or out on the street living. But for America, United States, it has to be a safe discharge. And if it isn't, that's where our role is to raise our hand to say, wait a second, this man is homeless, he's still on IV antibiotics, he can't get a prosthetic. You know, if he had a prosthetic and he didn't have an infection, he probably could go back to the street because that is what he was used to, and he could walk around once he got rehab. But this man had no rehab, no prosthetic, still with an infection. That was not safe to even consider sending him anywhere.
Yes.
And that's what our role is just to say no. And then
I can
in
imagine
the
it's a very
meantime,
difficult role.
it is a very difficult, it's confrontational. You know, administration gets upset because they don't want people who can't pay in the hospital or the insurances aren't covering. But what do you do when you don't have really any alternatives? You have to keep them. It's not safe.
Yes.
So it's difficult.
Now I can imagine it must be difficult to look patients like that in the eye, and then dealing with the administration side of it. It must take a toll on you as well.
Very stressful. A lot of burnout. That's what you hear a lot today. There's so much burnout. And, you know, resources are getting cut all the time. Healthcare is expensive. In the United States, we spend, I think it's up to, I forget the exact cost now, maybe $13 trillion, which comes out to about $1,800 per person. Now, every single person in the United States doesn't spend $1,800 on their health care. It's that small amount. There's a principle called the Pareto principle, where 20% of the people will utilize 80% of the healthcare resources. They're the 20% that we work with as case managers. That's small. Most people go through the healthcare system fine. It's a little bumpy. It can be a little complicated. It can be confusing, but most people go through it fine.
Yes.
And go in, get care, go home, go back to work. It's that 20% of the population that don't. That's who we deal with. But those resources, like to get people on medical assistance, to get them food vouchers, to get them housing, they're the things that are not easy because they don't exist out there. They're cut down, and it's really difficult. And a lot of case managers, they get into it. If they're not, you really have a passion for case management, they might not even last because it's hard to do that work. It's not easy to constantly be trying to be an advocate against the system that doesn't have resources. And why in the United States? That's what probably is the most frustrating, that we don't have those resources to meet the needs of people. you know, as I get older and my friends get older, we're starting to realize we need to prepare, and we needed to
Mm,
start preparing when we were like 22, not when we're 70. Do you start preparing for older age? Who is going to take care of you if you do get sick? Do you want to go
mm.
to a nursing home? If you don't, what resources do you have to bring somebody into your home? Because it costs money. It's not
Yes, that's
free.
right.
It's not free here in the United States. It might be free in other countries, but we do not have the resources here in the United States to meet the needs. And they say that less than, I think it's 11% of people have any kind of savings. So how are they paying for things that might not be covered by insurance? There's a lot
Mm,
of things that aren't covered because they're called custodial.
yes.
They're normal things that anybody should be able to take care of. But if you, I just have a case that I was working with somebody, the husband is 86 years old. He fell, broke his leg, his right leg is his right leg is left arm. His wife is 86. Has dementia. He was taking care of her and he fell. Now and they won't let him go to a rehab unit. I mean, it's like him and his wife both need to go to a nursing home. They
Mm,
have no kids, they have no family. Does he have a house? We might have to sell the house to get him into a skilled care facility or a nursing home.
mm,
I mean, it's just, and they're the things that happen. They're the emergencies that come up because people haven't prepared for the next step in their life. And
that's right.
that is what we as a country have to really help people. Because you have Social Security, you could have insurance, but it's not going to cover a lot of the things that you need when these emergencies happen. And if you're
Mm.
not prepared, these are the 20% of the challenges that we face on how to meet the needs of people.
No, that's definitely right. And this has been a very insightful conversation. But for my last question for you, you started out as a registered nurse. What advice would you give to other nurses looking to transition into roles such as yourself as advocates or case managers within the healthcare system?
Well, I think it's a career path. There's a lot of opportunities for nurses today to go into different areas. I always say it's important to get that basic training, get out of nursing school with your degrees and go work at a hospital and find out, like, use your skills that you learned in nursing school, because a lot of times they don't have the practical experience, the instincts that you have after you work a few years in the hospital, on a floor, in a rehabilitation unit. Even home care is a good training area for nurses because you get to see people in their homes with the basics, that what they can do, what they can't do, and you learn
Mm,
how to, I don't want to say improvise, but improvise. You learn how to make things work when things might not work because you have to. They're home.
yes.
And you have other people who can help you, like physical therapy, occupational therapy, people that come in to do those support systems that help people become more independent. But yeah, basic training first, but then look at what's available. Case management, patient advocacy is a really good transition from the bedside if that's something that you want to do.
Mm,
There's different parts of case management, like workers' compensation, where you work with injured workers, you work with pediatrics, kids that are sick, kids that have complex conditions, helping the parents to understand what's going on and the resources they need. So really, case management, patient advocacy goes from birth to death and
yes.
everywhere in between. That if you, depending on what you like, what you want to do, it's a good care transition from that hospital bedside nursing to these areas of practice.
No, by the sounds of it, it's a very challenging but also very rewarding career path that you've
Yeah, it
chosen.
is. I have to say, I've had a great career. I'm really on my, I'll say on my way out. but it has been a really good career. I've learned a lot, met a lot of good people, learned a lot from patients and families about how good or bad the system is and how I can help make it better just by listening. Many times it's just
Yes.
by listening that things improve, and showing people that you care, that empathy that you can give to people. And then looking at community resources. It's amazing what's out there. There is a lot of resources. People, we just have to find them. And that's part of our job, resource management.
Well, and it was a very lovely to have this conversation with you and also just see a different side of the healthcare system. Like we you have the healthcare professionals who work in the hospital, but we never actually think what happens once they're done and or if they're okay to leave. And this conversation has opened my eyes a lot, and I know our listeners out there will also appreciate your insightfulness into this.
Great. Well, thank you for the opportunity. And, if anyone wants to contact me, I'd be glad to talk to them about the two professions of patient advocacy, nursing, case management. Other disciplines get into case management, social workers, therapists. There's opportunities, mental health professionals are getting into case management. Again, just to help those people coordinate the care, get the resources they need, and find things. So I'm open. If people want to contact me, you can put my contact information, my
Yes,
email on with the
definitely will
webinar.
have it with this episode. Definitely will. Because I'm sure there will be a lot of people just to learn a bit more about what goes into case management and how to navigate that part of healthcare system.
Right. Thank you, Julie. Have a nice holiday, and it was great to meet you. Appreciate your time.
Thank you to you too, Anne. And for all our listeners out there, we will see you on the next episode of Healthy Talks.